Hey, good morning to the drive. It's Dr. Whitfield. Today, we're going to put this up on the fat transfer, fat grafting, category, and go to our channel and just dive in, learn more about fat transfers because they're very good techniques to use for enhancement. And if you go to one of the pages on the site or store, just make sure and sign up. Use your email. You'll get a free downloadable book about SHARP and inflammation and how to combat inflammation. The fat transfer, when I was in training in the 90s and 2000s, I remember doing a paper presentation and researching fat transfers, and fat grafting has been around since the 1890s. It's not a new procedure at all. They've done it for reconstructive purposes. The first one that I remember is 1893. A German surgeon did it for an orbital repair. And then there was a breast reconstruction in the early 1900s. The advent of liposuction coming to the country in the early 1900s from France certainly paved the way, and then with more and more liposuction procedures being performed annually in the U.S., it's a natural progression that there be more and more fat transfers. And then in the 90s, certainly I remember hearing about in training and everything, something called the Coleman technique. And Dr. Coleman's in New York. And when you started going to plastic surgery meetings, which my very first plastic surgery meeting would have been in Vancouver in 2004, we all learned about different techniques. And the Coleman technique was a standard technique where you harvest fats. They'd centrifuge the fat, so they put it in tubes after collection and then centrifuge it. And then they would re-inject it using cannulas that Dr. Coleman had come up with. And that was the Coleman technique. I believe those were his cannulas. But they were small cannulas. And ultimately, we all ended up kind of, if you want to think of it, technically using cannulas that were from the Coleman set to do fat transfer in other areas, because that's what we had. Fast forward, now if you were doing that, you would utilize different techniques and have different openings in terms of cannula size opening, and then in terms of being able to put the fat back into the target. So for me, the target tissue has predominantly been breast from the 2005 time frame until present. I've done thousands of fat transfers. I used to do for reconstructive patients after breast cancer reconstruction, I would do on average about 100 to 150 a year, and that was during 2004-2005 until 2019, and then starting in the similar time frame when asked about augmentation, especially smaller augmentations, those patients who wanted about a cup size change, those were ideally suited for fat transfer. There's a couple caveats. Always, you have to have enough fat in order to transfer, and Usually it's a lower body weight patient, lower BMI patient with smaller breast or buttocks that wants a fat transfer. For breast, the easiest situation is typically someone who's had, just like in a augmentation with an implant, the easiest situation is someone who's had children and breastfed, and then there's been a change in the breast size. It's increased in size, and then it decreased in size with discontinuing breastfeeding. That usually creates some sag or some volume loss as the skin has stretched and not completely maintain its tone. So those are the patients who are ideally suited, who don't want an implant-based augmentation to have a fat transfer. Depending on the number of areas you can take fat from, you can get 100, 200, 300 cc's of fat, even in a low BMI patient. And there are donor sites all over the body, the inner outer thighs, the front of the abdomen, the flank area, the sides, the lower back, the mid back, the bra area. There are different areas where you can get both access to minimally invasively with a 3 millimeter incision and take fat to help both contour the patient and make more favorable relationships in the ratio of the hip and the thigh, and the improvement in the waist, and then use that to augment the area, and we're talking about the breast. So that is the best case scenario. So they've already had a change in weight, which has resulted in a change in the breast, and we'll just use breastfeeding as an example, but you can have the same thing with a fluctuation in weight when someone goes up and down. That's the easy situation, and you could do that with or without a breast lift. If you want to just not have any scarring, then you use the existing skin and don't modify it. The more difficult situation is the younger patient, 18 to 25, who has very, very tight skin, not a lot of tissue, is unhappy with the appearance, but wants a larger breast size. And I've done this for different patients over time, and the discussion I have is always, this is going to take a minimum of 2 or 3 procedures in terms of fat transfer to get someone an increased amount of volume that they typically would feel comfortable with, because there's not been the stretching of the skin, so it's not as easy to put in a higher volume of fat. And if you just put in a high volume of fat in a really, really tight tight skin envelope of the breast, it's not going to work as well. There were plenty of studies done in the time frame from 2007 really until it seemed like almost a decade of discussion about fat transfers to the breast, because there was concerns. Fat transfers to the breast do not cause cancer. They've been done in post-mastectomy breast reconstruction for decades, so that is not of concern. It's not the cell type that would create that. But going back to augmentation, it's a volume related issue, and you can't overpressurize the space, or you could have difficulty with what we call the take or the healing of the fat. And there's always a lot of discussion and debate about fat transfers, and there hasn't been, in my opinion, a lot of studies to look at this in a approach that makes or creates enough understanding, given the sample. Let's say, for instance, if we're talking about any study related to our explant patients who then have fat transfers, about 2.2 million get implants annually, 300,000 in the United States. So you have to have a large sample size if you're going to discuss some of these issues. So when we look at fat transfers, there's not been a lot of high volume, meaning that a large number of cases done in certain centers and then looked at, because probably there's going to be, as you would expect, variables in technique. Some people will centrifuge or spin fat. Some people will inject by hand with a syringe, and then some people will use a fat transfer collection, processing, and re-injection system. I've used all those techniques, and I use the latter. I like it to be a controlled situation where the fat is never out in the open, it's all contained, and then I like to re-inject it under the same pressure. So that makes that works best for me. But that ends up creating a lot of, obviously, differences in what the patients are experiencing. And then I would, tend to say someone who's done reconstructive surgery for a long period of time, especially breast reconstruction, post-mastectomy breast reconstruction, contouring surgery, would have a lot of experience in fat transfers. They also have a lot of experience in typically doing fat transfers in general. Those are going to be folks who worked in usually medical centers doing cancer reconstruction typically, and if they're doing a lot of DIEP, free flat breast reconstruction, or other forms of autologous breast reconstruction, which is using your own tissue, then they're going to have a lot of experience with using fat in the post-mastectomy breast reconstruction patient to fill in contours, to add volume, to improve some of the shape, because when they're doing those techniques, those tissue techniques for reconstruction only allow you to at one time transfer the amount of tissue that's available, and that was principally the standard of care we abided by. So whatever thickness of tummy tissue or inner thigh tissue, if you're talking about that, was able to be transferred at one time. The tummy was overwhelmingly used in those patients, and that was called the DIEP, free flat breast reconstruction. I was talking to a patient about it yesterday, and I stopped doing microsurgery in 2019, transitioning out of reconstructive surgery into just solo, basically concentrating on aesthetic surgery, minimally invasive surgeries of the breast, fat transfers, skin tightening, contouring. So I've maintained a high volume of fat transfers because of the nature of our practice. And now we have another surgeon, Dr. Chung, who's performing fat transfers in the practice, and will typically grow that portion of the practice. I think that's going to be something of more and more interest. So we'll continue to add surgeons to provide fat transfer services. I feel like it's a really excellent opportunity for patients to use their own tissue. I do get asked why there's so much discussion about both the take or the healing of the fat and how much is there over time. So fat has to have, obviously, the right environment. So you have to put it in the right place. And the right place is underneath the skin and above the muscle. Underneath the skin of the breast. Think of like the shirt pocket, the front pocket on a shirt. So that is how I think about where we should put the fat. So if that front pocket over the chest represents where the fat should go, it's beneath the skin and above the breast. So that's what you fill. And once that pocket, if you will, as using that as the visual, is full, then we don't add any more fat, because we're not going to make the result better. We're going to harm potentially the result by creating too much pressure. So allowing the fat to heal, and all of the important substances that are transferred with the fat. There's different cell types: periocytes, vascular cells, stromal cells, fat cells, of course. And then there's the adipose-derived stem cells, which that is and was a focus of my research. And certainly, I believe there'll be more and more research devoted to adipose-derived stem cell therapy, both in our country and certainly in South America and Europe. And that is where I feel like we have the most room to grow. But all things being equal, I like people to run the SHARP program to, one, let us understand their genetics and how to detoxify. Two, you're looking at their tox burden. So I think fat transfers work uniformly well. The only variable changing in the equation is the patient. We're not changing technically what we're doing. We're using the same equipment. We have the same areas we typically will take fat from that we discussed already. It's really about creating an optimized environment for the patient to have a fat transfer. So in many programs and shows, you'll hear people talk about improving the terrain. The way I think of this is identifying opportunities to just remove toxins from whether it's your work, your home, the food you eat, the air you breathe, the fluids you drink. Those are critical. And then having the right macro and micronutrients, so we concentrate on high quality protein, high quality fats, eliminating all ultra processed foods. Don't eat anything out of a bag or a box. That's not going to help you. I don't want people having put on weight for a fat transfer that then is not really going to be part of their journey moving forward. We look at gut health. That's incredibly important. Triggers in your diet. So food sensitivities. Yesterday I had a patient have an extreme problem with monk fruit, which is a sweetener that's found in all sorts of gluten-free products to sweeten them. And we look at metabolomics. We look at hormone balance. Hormone balance is very important. You want to have patients have the proper hormone balance, so the correct levels of estrogen in the form of estradiol, estrone. Looking at total testosterone, free testosterone. Thyroid function has to be euthyroid, which is basically normal. Can't be taking GLP-1 agonist because they do work, and they will burn fat. So tirzepatide, semaglutide, I don't want you taking those. I have patients who routinely get on calls requesting fat transfers, but then they're taking a peptide. Those things don't align. So to learn more, go to my website, www.drrobertwhitfield.com. You can sign up for our newsletter. You can download Sharp, get started on reading that, and look forward to the next time.